and I am pleased to introduce Senator Tony Hwang, who is a ranking member. And Senator, you have 10 minutes.
Thank you, Commissioner Mays. And I want to thank you for you and your staff for making this an opportunity to have a public hearing in the LOB and via Zoom for us as legislators to be able to voice and, if not possibly, vent some of the frustrations of many of the constituents that we represent. So before I begin, I just wanted to kind of give a caveat to the insurers that are here. Thank you for being here. Thank you for your role in being a business partner in the state of Connecticut. But I understand that you're the messenger here. You are the compiler of healthcare costs, which in this state and in this country is unaffordable, unsustainable, and an incredible burden on the consumers and the constituents that we represent. But I will echo what Assistant Attorney General Ryan said. I've been coming to these meetings for the past 10 years, and every single year it is a rate increase. You could have surprised one of us and knocked us on our floor by saying, hey, this year we're asking for a rate reduction, but it's never happened. You know, the landscape might have changed, the cost factors might have changed, but one thing has remained constant. You continue to ask for rate increases. And that is where the frustration and the venting you will hear from many of my colleagues and many of your consumers, your ratepayers, that feel as though you are tone deaf, that you are not listening to the struggles of them. Combined with what people read about Wall Street profits, what people read about outlandish executive compensations, and all the largesse of corporate benefits that are at the backs of ratepayers in this state. So this is what we're looking for today. Is I'd like to hear from you some of the solutions that we as legislators. It is not a batting day. It is important for us as a legislator to work with the governor's office, with the Office of Health Strategies, with the agencies, and as legislators on a bipartisan basis to find some solutions. But the first question I have for you is, do all of your businesses service and administer self-employed insurers, meaning large corporations? Just a yes or no, through each of you, if I may.
Yes.
Yes.
Yep.
Do you continue to raise double-digit rates in your negotiations with those companies and not get the pushback and the negotiations and the consideration of cost efficiency that the AAG Ryan talked about over and over in cost indexing? Do you?
I can speak to that first. The trends utilized for small group are very similar to the trends utilized for large group as well as self-funded employers.
Do you ask for double-digit rate increases every year, and unfortunately, on the backs of small businesses and individuals, get approved by those entities?
Well, it's an ERISA plan, so, and if it's self-funded, a lot of those decisions are really made by the employer and the choices they make. But in general, sometimes they do have double-digit rate, if you will, cost increases, and sometimes they don't, depending upon what types of applications of, if you will, affordability initiatives in the larger group market. Could have disease management programs. They might identify a particular risk that's unique to their employer population, and they'll go at looking at ways to manage that membership a little bit differently. There could be the list can go on, but that evaluation happens. As it relates to small group, we do similar things like that. So we do have medical management programs and things that do take care of populations where if you're an employer and you're in small group, you're not very credible by yourself, but within all of our clientele, not just here, but also on a national basis, we have programs available for helping to manage and support members in those times of need as well.
Thank you, Mr. Brandt. Mr. Mitter?
Yeah, so we have a small, large group ASO business, and they get the same rates that we have in our commercial business, insured commercial business.
Mr. Rousseau?
Yeah, and ours will vary depending on the customer. So much like my colleague here too was saying before, actuarially we're projecting ahead. So at the end of the day, a large group self-insured client, we're going to treat the same way as we would the entire small group block or the individual block. We're going to trend forward and see exactly what that claims experience is expected to look like and base the rate on that.
Thank you. And the reason I asked that question is, just as the AAG Ryan and Dr. Gifford articulated, there needs to be more of an engagement in the solution process, allowing our insurance departments and the various agencies with the expertise to be able to help in negotiate and to be able to look for best practices and not simply count on your request every single year with your actuaries who are very talented, but your basis based upon your perspective, not the other perspectives we've been able to gather. And so the first question I have is benchmarking as one of the solutions. What is the enforcement factor just based on that chart that was presented by Dr. Gifford? We've exceeded the benchmarking average basis. What is the incentive and what is the potential enforcement if you don't meet those benchmarking criteria that we've resulted from?
Yeah, I mean, from an Anthem perspective, I think it is a part of every negotiation that we have with any provider contract. So I think it's always an element there. The enforcement of it is difficult. So at the end of the day, again, when you don't have that negotiating power, you're dealing with a very consolidated hospital system. That's where I think the difficulty comes into play. But we actively have those conversations. I think it's, again, having that forum where we're all at the same place at the same time talking about it outside of just the simple renewal that happens or, complex renewal that happens every few years with a hospital system. It can't be a one and done and then you come back 3 years from now and see where you land. It needs to be more proactive on an ongoing basis, and I agree there.
Yeah, sort of get back to my earlier theme, there are other states that have hospital systems do performance improvement plans directly with the regulator. And that is something that we should consider here. So again, a sort of direct action, not through the insurance company, to deal with the hospital system market power.
I just would comment that I think those are fair suggestions by my colleagues of both companies. We don't have anything additional to add. Senator, thank you.
Thank you. Now, two of the major factors that's been presented by your actual analysis was looking at hospital cost, and we've addressed some of that in regards to benchmarking and your fee-based negotiations. The other is pharmacy, prescription drugs. Now, as I understand, you have a vertical integration with some of your organizations that we're talking here. Anthem has obviously Domani RX, which is a new name, right? Which is the combination of Humana and an IT organization. And then United Health has Optima RX. And just with Connecticut Care, you use Express Script, but you don't own them.
That is correct.
Right. But in regards to the two entities that have ownership in PBMs, that dictate prescription drug prices, we talked about hospitals and the look at their vertical integration and looking at all their cost analysis and P&L. Wouldn't you think that would be applicable to you as an insurance conglomerate to look at your P&L relative to the PBM being a profit center or a loss center to your rate requests? As you talked about hospitals and their vertical integration and their cost considerations, why have we not considered your relationship, your ownership of PBMs as part of the cost of healthcare in your rate setting request? So this would be applicable for Anthem as well as for Connecticut. United Healthcare, I'm sorry.
Yeah, so for us, it's Carolina RX is the name of the pharmaceutical PBM that we have.
Thank you.
But for me, it's the same issue that we're talking about with the hospital systems. We don't dictate the cost. So at the end of the day, the pharmaceutical company is the one that's dictating the cost. We can negotiate on what we feel is an appropriate price from there, and I think that's where we're probably struggling. When you have all these new drugs coming to market, and I mentioned it in my opening statements as well, there's value in these new drugs coming to market and saving people's lives. We all know that, but at what cost? That's what we're here to address, right? So at the end of the day, it's a lot of money, and we need to figure out how we're going to address that piece of it first. And it is going to come down to stronger negotiations with the pharmaceutical companies, just the same as with the hospital systems for us.
Thank you for the question. While OptumRx is a UHG company, they are separate from United Healthcare. But if you broaden the conversation to negotiating with OptumRx, and I'd mentioned earlier, we actually have our own team that negotiates with them. The context would also be helpful to broaden it to not just small group, but it's also in large group. We compete with folks at this table in the large group, fully insured environment. But on a self-funded basis, we also compete on a national basis, not just with the folks at this table, but many national self-funded carriers as well as TPAs. So we're fortunate for, if you will, Connecticut small group ACA, in that we have leveraging power of all those other entities, in addition to the fact that we want to compete on a national level, but also on a local level, say, with a TPA that's got self-funded business that uses a third-party pharmacy PBM. So we do directly compete with our competition relative to these agreements. So we are motivated to be competitive and have the best quality and affordability outcomes relative to the PDL that we do provide.
I appreciate the answers, but for me as a consumer and looking at a perspective that you report all your business operations to Wall Street as one income stream, but when you make these rate requests to the insurance department for setting, you look at your healthcare cost, and it's only based upon your healthcare costs. It does not encompass your portfolio of business operations. I struggle with that. I struggle with that straight pass-through to the consumer in regards to healthcare costs when other parts of your business benefit. And when we see the Wall Street returns and consumers continue to feel the sting of additional rate increases, while we see the buffer of your other business and vertical integration on your business, I struggle with that. And I feel that same struggle in a parallel that we're seeing right now with consumers as it relates to our electric utilities. It is the same system that reviews rate requests based upon energy generation, but not on their business profit centers elsewhere. Again, it is the consumer and the ratepayer that bear the brunt of your actuarial analysis of purely healthcare delivery, not the basis of how you run a business. I hear criticisms in hospitals and their vertical integration, but when it comes to how you operate as a business and how you are setting rates to this request to the insurance department, we're only focused on your cost of healthcare delivery, not the profits that you make in other parts of your business. So perhaps that may be an opening of discussion when we're looking to reduce cost. One last question, if I may, is, at the indulgence of the Commissioner, is how can we manage a system that does not go into some of the advocates of a government-run system? How do we channel and leverage the expertise and the experience that you all have, and in Connecticut being the insurance capital of the world, how can we create a better system where you are viable and you are successful, while at the same time leading the marketplace? As Dr. Kipfer promoted in the chart, Massachusetts, our neighbor, and Rhode Island have significantly reduced costs. Maybe it's the premise that Connecticut consumers can pay, but I'm telling you loud and clear, they can't. They're compromising food on the table and benefits that they need to take care of in order to pay for health insurance that they hope they never use. So my ask of you is, we'd love to have you come to the table as the AG, as well as the Office of Healthcare Advocates and the health strategies and the Commissioner. I ask for you to come with real solutions and real, genuine efforts in recognizing that in the profit you make at the cost of your ratepayers, that you need to be more transparent, you need to be more accountable of your P&L, and you need to respect the consumers that pay your rates. So, Commissioner, I appreciate the opportunity. And as I said earlier, we're representing our constituents as elected legislators. We're going to give them a voice that they feel as though that is not being heard, and that the reactions and some of the claim approval or rejection processes are tone deaf. So I hope you'll take that to heart. And again, as I said earlier, I appreciate you being here, and indeed you're the messenger of being a cost compiler, but you're also a big part of the hopeful solution that we need to have. Thank you, Commissioner.
Thank you, Senator.